management population, hereafter referred to as the rate registry. The clinical implications of atrial fibrillation and atrial tachycardia, hereafter referred to as ATAF, documented by implantable devices, including pacemakers and defibrillators, remain uncertain. The rate registry is a prospective, outcome-oriented registry designed to document the incidence of ATAF with associated clinical data in a large group of patients with newly implanted cardiac rhythm management devices. Our hypothesis was that ATAF episodes in the rate population would be associated with pre-specified adverse events, including hospitalization for ATAF itself, heart failure, stroke, and death. Baseline demographics were collected. Follow-up was performed every 6 months for up to 2 years, collecting device data, including recorded electrograms, as well as clinical data relating to adverse events. All hospitalizations, ER visits, and in-hospital deaths were adjudicated by an adverse events committee blinded to the electrogram data. We estimated that as many as 130,000 electrograms might be recorded during rate registry follow-up. Therefore, we chose to adjudicate 2 samples from our data. The random sample consisted of 300 randomly chosen pacemaker patients and 300 randomly chosen ICD patients. The size of the random sample was designed to provide 95% confidence of defining the true incidence of ATAF in our population. The case control sample consisted of all electrograms from all patients with predefined adverse events, referred to as cases. In addition, we adjudicated all electrograms from 2 case controls for each case, matched by device type, age, and gender. Electrogram adjudication was performed after a training period by 8 teams, each team consisting of 1 physician and 1 field clinical engineer. Consensus of the team was reached after each member adjudicated independently, and an additional physician was available to resolve differences when necessary. For purposes of this presentation, ATAF incidence was defined only by adjudicated electrograms. Short episodes of ATAF were defined when both the onset and the offset of an episode were documented within the same electrogram tracing. Long episodes of ATAF were defined when the onset and or the offset of an episode was undocumented within 1 tracing. Here are results from the rate registry. During 2007 to 2012, we enrolled and followed 5,379 patients, including 3,141 patients with pacemakers and 2,238 with defibrillators. Median follow-up was 23.6 months. There were 2,200 total hospitalizations and 11 in-hospital cardiac deaths. The total number of adjudicated electrograms was 20,153. An additional 350 out-of-hospital deaths have not yet been fully adjudicated and are not included in today's report. Shown here are demographic results from the rate registry. Selected variables are shown in the left column in blue. Random sample pacemaker patients are shown in the top panel and ICD patients in the bottom panel. Note that pacemaker patients were older than ICD patients by about 8 years. The most common indication for pacemakers was sinus node dysfunction. The indication for an ICD was primary prevention in approximately 4 out of 5 patients. For pacemakers, here are the demographic results for cases, patients with an adverse event, and controls, with 2 controls for each case. For ICDs, here are the demographic results for cases and controls. A higher percentage of controls than cases had an ICD implanted for primary prevention, while a higher percentage of cases than controls had an ICD implanted for secondary prevention. For ICDs, ejection fraction was in the 30% range, and not different between cases and controls. As was true for pacemakers, more ICD cases had prior myocardial infarction than did controls. Here are the adverse events reported in the rate registry. Shown in the left column in blue is a list of the predefined adverse events. The next two columns show the number and the risk of these adverse events for pacemaker patients, and the last two columns show the number and the risk of these adverse events for ICD patients. Risk is measured as the number of events per 100 patient years of follow-up. The most common adverse event was a hospitalization for heart failure in 84 pacemaker patients and 181 ICD patients. Shown on this slide is the incidence of ATAF in the two rate samples. The upper panel shows results from the random sample, and the lower panel shows results from the case control sample. From left to right, the columns show the device type, the number of patients, months of follow-up, the number of patients with any documented ATAF, the number with any long episode of ATAF, and the number with only short episodes of ATAF. Note that for the case control sample, the months of follow-up represent only follow-up to the first adverse event. Similarly, adjudication results are from electrograms recorded only up to the time of the first adverse event. In the upper panel, note that about half of the random sample, both pacemakers and ICDs, had ATAF. In the lower panel, note that 2/3 of the adverse events occurred in the ICD patients, even though only 2/5 of the entire rate population had ICDs. For both pacemakers and ICDs, more cases than controls had any long ATAF episode, and slightly more controls than cases had only short ATAF episodes. Statistically significant differences between cases and controls are denoted by asterisks. Inter-observer agreement for ATAF was 93.4%. Shown on this slide are the results from a multivariate logistic regression for the pacemaker patients. Note that long episodes of ATAF were associated with adverse events with an odds ratio of 1.84. Association of long episodes of ATF with AF hospitalization and heart failure hospitalization did not reach statistical significance. Patients with only short episodes of ATAF were not at increased risk. Shown on this slide are the results from a multivariate logistic regression for the ICD patients. Note that long episodes of ATAF were associated with adverse events with an odds ratio of 1.56. A strong association of long episodes of ATF with AF hospitalization itself was demonstrated with an odds ratio of 5.86. As for the pacemaker patients, ICD patients with only short episodes of ATF were not at increased risk. A further analysis was done to see if higher numbers of ATAF episodes increased risk of adverse events. ICD patients with higher than the median number of ATAF episodes were at higher risk for adverse events, and especially for ATAF hospitalization with a risk of 10 times. A relation of higher than the median number of ATAF episodes with heart failure hospitalization did not reach statistical significance. In conclusion, the rate registry documented ATAF in half of the device population within 2 years. Patients with only short episodes of ATAF were not at higher risk for adverse events than those without any ATAF. Long episodes of ATAF were associated with adverse clinical events. Specifically, an adverse event was more common in both the pacemaker and the ICD groups with any long episode of ATAF. In the ICD group, any long episode of ATF with any long episode of ATF, hospitalization for clinical atrial fibrillation itself was much more common. Also for ICD patients, a larger number of long ATF episodes was associated with higher risk of any adverse event and a much higher risk of atrial fibrillation hospitalization. Slide off. Thank you for your attention. And, available for time.
Thank you, Mr. Swiryn. The discussant will be Dr. Bernard Gersh, who's going to discuss both registries, GulfSafe and the Red Trials.
Mr. Chairman, ladies and gentlemen, thank you for the opportunity to discuss these two very interesting and excellent papers. You can bring the slides up for me, please. I have three potential conflicts of interest in that I've consulted from Medtronic that is producing one of these devices that is used for monitoring Bristol-Myers Squibb and also McNeil Janssen, who are involved in the new anticoagulants. Now, in terms of the Gulf Registry, I really do think that the investigators from 6 countries in the Gulf and 23 hospitals